Are you thinking? What's going
I'm
on?
thinking.
You really struggle with intros. Yeah.
You good?
I'm great. Yeah, great.
Hello, Brian.
Tom, it's good to see you in my living room. This is great.
Happy Christmas.
You as well.
Why are we here?
We're here. We have a collaboration with Topline Bio. We did a series of ASCO videos. You'll remember some ASCO recap videos of the highlights. And we decided to do a year in review, 2024 in review, GU cancers, kidney, bladder, prostate, and we're going to take sort of a meeting by meeting approach.
It was a big year.
It was a big year for data.
Are we going to talk about absolute highlights, or should we do it in chronological order? Have you got a plan?
I had a plan and you changed it.
I know.
We're going to go chronological. We're going to start with ASCO GU.
Okay.
Big data comes out at the meetings.
Best data at ASCO GU, was it 564 overall survival pembro? Was that the best data there?
I mean, it's hard to argue it wasn't.
Okay, great. Let's start with that.
So Keynote 564, adjuvant pembrolizumab in renal cancer. We had seen the DFS curves and data before, and it was approved on that basis. I think there were 2 of those updates.
Hazard ratios in the 0.6s.
Correct, in the publications. But we saw for the first time, the final or the significant overall survival benefit to adjuvant pembro in this setting.
0.63.
Right, also in that same range, which I don't know if it surprised people. We hadn't seen that in other solid tumors. Certainly the other PD-L1, PD-1 based adjuvant trials in renal were negative. We won't really talk about the details.
We've done podcasts on that. If you want to look at that, go to the podcast.
Podcasts on all of this.
Yes, yeah.
And a significant benefit. Now, there was some controversy there, I think, from the microphone after saying, well, only about half the patients got subsequent immune therapy. And,
yes.
So it's kind of that early versus late discussion. But there was a fair amount of patients who got local therapy as salvage, right? And so, as I think we've talked about before, there's good reasons and bad reasons not to get subsequent immune therapy in that trial. Bad would be my disease progressed too rapidly and I couldn't get it, or I'm in a country where I don't have access. Good would be I have this indolent recurrence in a solitary lung nodule and I can get it radiated or something.
There was also a short bit there around the data, the way we collect data in clinical trials. We started to explore how accurate are CTC criteria at assessing immune-related toxicity, because they weren't designed for that, they were designed for chemotherapy. And then the second bit was how accurate are you collecting these subsequent data? Because we also had, we're not going to talk about it in a second, but we had some adjuvant bladder cancer data where, again, only 66% of patients in the US getting first-line treatment for urothelial cancer. You'd expect that to be 100% or 95%.
Yeah.
And I think there are 2 things. I think the first thing is giving your most effective treatment early is important. You've always said that, number one. And I think the second thing is I think we need to change the way we assess adverse events, and we need to be more robust in subsequent therapy data if we're going to take that data seriously, and we are taking it very seriously.
I agree. I mean, I think when we're designing trials, the sort of global, we don't necessarily think, 5-year, 10-year follow-up, subsequent data, but we need to start thinking like that because we just saw 8-year follow-up for Ipi/Nivo, right? We need to start thinking about we're going to be following these patients for a long time. That's a good thing. And if we're going to start wrangling about with this percentage or that percentage, we should at least have accurate data.
I think that's really important. Accurate data if we're going to have that debate. If we don't think it's accurate, we don't need to have the debate.
I think it's hard not to have the debate. I mean, I think they were good points. I can sort of see both sides of it.
I think I was supportive of that. I think we should have that debate. I think we need to collect the data robustly, but we also need to be robust about how accurate that data is.
Agreed. Anyway.
Do you want to move on to HIF,
So
belzutifan?
let me just finish up the adjuvant pembro. So I think adjuvant pembro is a standard of care in high-risk disease. In my practice, I tend to give it pretty broadly, but definitely more towards that higher risk. There is a small incidence of life-changing, life-altering toxicity. So, on balance, and I think everybody sort of interprets it differently. I still have some concern about that resected M1 population, that it's under treatment. Discussion for a different day, maybe.
Yes.
But no question it was big data early in the year.
And and we had guidelines meetings through the year, and it was given sort of level 1A evidence. And I think the feeling at the moment is you should be discussing this with your patients.
For sure.
But you have to discuss the adverse events as well as the potential benefits.
And potentially even the other negative trials, right? I mean,
yeah.
And so, but I think it's different. In my practice, it's probably about 50-50, even if I offer a patient sometimes want it and sometimes don't. I think in other geographies and other parts of the world, those percentages probably shift.
I think it's higher than 50-50 where we are, but that's kind of where we are a little bit. I think patients probably are looking particularly those patients who have been otherwise well during their lives, and this is the first thing to go wrong.
Yeah.
And the risk of kidney cancer coming back when it gets to about 40%,
I agree.
Kidney cancer coming back. You're on therapy for the rest of your life. You may be cured if you're lucky with immune therapy, but that's worse than having diabetes.
Agreed.
Okay.
I agree.
There was also, I'm going to talk about the belzutifan data, the quality of life belzutifan
Sure.
data. I think you presented, or Tony, or you presented in the 2023, presented that PFS advantage and that immature OS signal.
Yep.
I think that was ASCO 23, and then ASCO GU 24. We looked at the quality of life and adverse event in quite a lot of detail. And I think it's fair to say from that the belzutifan toxicity profile, which appears attractive, and although there's anemia and there's some hypoxia and there is some fatigue and there's some nausea, I think it's easier tolerated than VEGF TKI therapy. And I think this endless sequencing of VEGF TKI therapy with the toxicity associated with that is probably less appealing than giving belzutifan third or fourth line. And the quality of life data supported that on multiple levels.
Agreed. You and I have debated and discussed the accuracy of quality of life data. I don't know that we need to get into it now, but it's very believable here. In other settings, I think the QOL data, and you're not really sure what it reflects here, you and I both given plenty of this drug and know that it's well tolerated. I will say, I've sort of evolved this position over many years. TKI toxicity is manageable, but over time they wear people out.
Yes.
And I think with belzutifan, most of the side effects occur within the first couple months.
Yes.
And my clinical experience outside of trials has been you sort of know in the first few weeks, either a patient's going to tolerate this or not. And if they do, then they could tolerate it for months and months. And we know years from the BHL syndrome population, right? And those patients have been on 4 and 5 years.
Yeah.
Yeah.
And I think the story for me with that drug is let's say you give whatever immune therapy first. We're not going to have that debate now, I promise.
Please.
But you give a combination, PD-1 based combination first, cabozantinib or axitinib second, and then belzutifan seems like an attractive alternative to anything else at that point. Would you agree with that?
I think that's where most people are slotting is in that third line therapy. There's some second line use, but I don't know that the data quite support that yet.
I'm not super keen on that.
Yeah, and so I think, there are certain patients perhaps, but I think most people feel more comfortable with a cabo or whatever. And then by the time you get to the third line, you're clearly in a palliative setting. Patients become more symptomatic from their disease, and you're trying to make sure you're helping the patient more than you're hurting them.
There was some prostate cancer immune therapy data, PD-1 therapy data, or it was PD-L1 actually. It was cabozantinib, atezolizumab versus an RP, Contact 2. Do you want to talk about that very briefly?
Yeah, so this
Niraj did a great job.
Niraj presented these data. It was Contact 02. There had been some previous data of cabo monotherapy. This is sort of way back when that showed it was definitely active. We all remember those bone scan changes from cabo that Maha Hussein showed, gosh, I don't know, it might be 10 years ago now.
I still think that has a hangover effect in kidney cancer.
I agree.
I still feel, I've spent a lot of time in kidney cancer on cabozantinib and bone mets. I can't see a particular benefit compared to lenvatinib or axitinib.
I don't disagree, yeah.
But because of that, we've still got this bone thing going on.
It was sort of one of those aha moments where you're like, oh my gosh.
Yes.
So anyway, cabo has that, monotherapy has activity. It wasn't approved. And it was interesting that those old cabo studies had an RPFS advantage, but it was kind of before that was accepted.
Yeah.
We said, oh, we need OS, and this is just RPFS, et cetera. And so it didn't move forward. I think there were 2 phase 3s that didn't result in registration. So this was cabo plus ateza, which has actually been studied in multiple solid tumors, right? Kidney cancer and others. And what Niraj presented was kind of the same thing, an RPFS advantage. I don't remember the numbers, I think it was like 6 versus 4 months, something like that. But, sort of a standard RPFS advantage. At the time of ASCO GU, there was no OS data. There was no significant OS data. That came later at ESMO, we can talk about. But I think there was some skepticism because immune therapy has this checkered history in prostate. It just hasn't been robust. And there's little signals here in this subset and some ipi-nivo data. But
it didn't have that third arm. It didn't have that cabo alone.
It didn't have cabo alone, correct.
And talk about the control arm for me, because there was some controversy around the control arm and the liver mets patients. That actually caused quite a lot of, in the prostate field, I felt that tension, from a distance. I felt those shock waves come through.
I think one of the things that has been a theme in the last year in prostate cancer is ARPI switch, is hormone switch and appropriate control. It was the control in Vision, lutetium post chemotherapy. It's been the control in Contact 02 and some other studies, the PSMA4. And, in clinical practice, do I do that? Yeah, sometimes. I have a little frail patient and I want to get away with an old drug and et cetera. But I don't think the prostate cancer community really feels like that's a robust standard of care. Could be chemo, could be whatever, depending on the circumstance. So that was the control here. And to your point, there was about 25% of patients that had liver metastases. And so I think some people said, and I think Kim Chi gave the discussion, was like, well, it's especially in those patients where you wouldn't use hormone switch.
Yes.
You might use it in a node only or limited bone disease, et cetera, a different phenotype.
Yeah.
But in visceral disease, those patients probably need chemo.
Yeah.
Right? Even if it's not curative, it probably has a greater effect, or you want to use chemo in that setting.
Yeah.
So I think that ARPI switch controversy has persisted. I think trials moving forward won't do it. That's my sense.
Hans Hammers got very upset at our Uromigos meeting a few months ago when we used the term immune therapy for PD-1 therapy, because he was very clear that CTLA-4, PD-1 are very different from each other, but also T-cell engagers are very different. And
Yeah.
T-cell engager data really did start, I think, in a big way at ASCO GU. We did a session on it at our Uromigos meeting a couple of months ago. Do you want to talk a little bit about the progress that's been made with T-cell engagers more broadly in prostate cancer?
I mean, T-cell engagers bring T-cell to the tumor, right? So it's a bispecific CD3 positive T-cells coming to a tumor antigen. I think the ones that have been tested clinically, PSMA, DLL3, which is on small cell neuroendocrine type tumors, and STEAP1, which Kevin Kelly presented some data. I'm not sure the first time that was presented, but he also updated it at ESMO this year. And I think broadly what we've seen is there's activity as measured by PSA declines for what it's worth.
Yep.
Some RPFS that to me, I don't know, look that impressive as a group, but it's sort of that immune therapy, the story of immune therapy since the days of low-dose interferon back before you were born was there's always that subset that does really well long-term. And that's what keeps you coming back,
Yes.
right?
Yes.
That anecdote, right? We can't talk about immune therapy without talking about, well, I had this one patient, et cetera. Anyway, different story. But what we've seen with T-cell engagers is there's activity. Certainly some of the objective response rates. We've definitely seen activity in a subset of patients as yet undefined from a biomarker perspective. But from my chair, it's also been toxicity. The cytokine release syndrome, CRS, which happens in a decent majority of patients, can result in ICU admission and vasopressors, and figuring out, do patients need to be inpatient versus outpatient? Seems like the whole field is
there
maturing.
a best target?
I don't know. I mean, PSMA seems like a great target, right?
Yep.
In
And
other areas?
Combinations with immune therapy? Combinations with PD-1 therapy.
I think we're getting there, right? I think we'll get there. And this was from our Uromigos meeting, I think the general consensus was there's activity. Yeah, there's toxicity, but you know what? There's toxicity to cisplatin, and we learned how to deal with it. And to PD-1 inhibitors, and we learned how to deal with it, et cetera. I mean, we're giving CAR T cells and things that certainly cause more of the cytokine release syndrome. So I think if there's activity, oncologists will learn how to manage the toxicity. I think that's the state of that field.
Andrea Polo presented her investigator-initiated randomized phase 3 ambassador adjuvant pembrolizumab data at ASCO GU to start with. She updated it in ESMO. But let's talk about it now if we can. We know a little bit about that story in that nivolumab also had shown a PFS signal, but no OS. We hadn't seen the OS. Right. And we showed a clear, or Andrea showed a clear PFS signal, which actually was very, very similar to the checkmate data, although the PD-1 biomarker didn't work, but there were different biomarkers, very complicated issue. No OS, very flat. Right. And there were some questions about censoring, and there were a few questions about some crossover in the US. Because
nivolumab was approved in the US in the tail end of that trial. I think they stopped a little early, not a lot, but a bit early.
A little bit early. And so that started a tsunami of bladder cancer data, which then went into EAU, and there were two data sets presented there. We then saw the OS signal of checkmate 274, adjuvant nivolumab. Now, it wasn't mature or final, and it wasn't statistically finished. We'd heard that actually they were waiting for it to come out, but they showed it early, I think partly because the Pembro data had come out with no OS.
I think it's because you berated Matt Galsky on several podcasts about it.
I think he held his own pretty well, to be honest. But the story there is that we did see that data. It's not final, but it's not statistically significant yet. The curves do go apart though, and the OS signal seems higher in that PD-L1 positive population.
You've been more critical of those data, I feel like you don't quite believe it, and the OS we hadn't seen, and you were sort of skeptical of that. I mean, have you shifted?
I shifted a little bit because when we hadn't seen the OS, inevitably you never know, and strictly speaking, I think they could have they looked at EAU, and we'd been told it was more difficult to look. you and I have had lots of difficult discussions with statisticians saying what you can and can't do. And sometimes what clinically makes sense doesn't always make statistical sense. Now, you can sometimes have that discussion and that debate, and I think seeing Ambassador probably pushed that debate saying we probably do need to stop now. And I understand that, and I've been in so I don't think anyone was, doing disingenuous around it. I just think the statisticians said this was the rules, we're going to obey them, and everyone said, well. And then I think that balance changed when it became apparent that this had FDA and EMA approval and the survival wasn't there for a different drug. And I think when we did see it, I think, it was encouraging. Now, it wasn't statistically positive, and it had all the caveats of 564 in kidney cancer, but without significant OS, and that's important.
You don't have Nivo approved in the UK for adjuvant therapy. Oh, you do?
We do, yeah.
But based on the PD-L1 biomarker.
Based on the PD-L1 biomarker, and the data, it does look better in that PD-L1 biomarker subset.
Even though you're not a fan of.
No, I wish we hadn't done it, because we then showed in Figure 11 data for the ctDNA negative population that remain negative. So it's a select population, and I think there was a podcast on that with Matt, which I think was. I think it described really carefully exactly what that study shows. What it shows is if you're negative and you remain negative, your relapse rate is really low.
Makes sense.
And it makes sense, but it reinforces the accuracy of the biomarker, but doesn't say you should be using it more. I know it's currently being used in the FDA and in the United States. And and Andrea Apollo at our Uromigos meeting, I think, described it very nicely. He said, we're using it, but we don't yet know enough about it. And there was some Tombola study data at ESMO regarding ctDNA. And I think pulling that, and that's again in the adjuvant setting, I think putting that together, what we're really waiting for is the IMvigor 11 trial, which is the randomized study of patients who are positive, who become positive, who are randomized to atezolizumab or placebo, PFS and OS. And that study has completed its enrollment. There's also the modern style.
A question about that. Do you have any concerns because atezo's hasn't shown benefit in the adjuvant setting yet, PD-L1 inhibitor, that if it doesn't, that ctDNA, and you're a big ctDNA guy, like it won't be an adequate test of whether ctDNA is a useful biomarker, if you know what I'm asking.
Yeah, so we're not going to have 20 minutes on ctDNA now.
Thank God.
And we've made lots of podcasts on that issue, so that is good news. But what I think is there are two things going on. I think ctDNA in the neoadjuvant setting with ctDNA clearance
we'll talk about it.
is slightly different from ctDNA in the adjuvant setting which is MRD.
Yeah.
And I think that if IMvigor 11 is negative, there's another study called the modern trial, which Stephanie and Matt are doing together. And I think that study is asking a similar question with nivolumab. I feel it's very likely to be positive for PFS. It's not powered for OS.
For DFS, yeah.
It's difficult for DFS. It's not powered for OS. It's going to be, it's a huge undertaking to do this work, and I think we've managed to enrol 250 patients or something along those lines. We'll have to see where that story lands. I'd like to see an OS trend in the right direction, but what do I think is going to happen? I genuinely don't know.
Yeah, I mean, it makes all the sense in the world that ctDNA as a marker of MRD or whatever would have clinical utility. Again, in the US where we have access, a lot of people use it very routinely. I'm a little reluctant because I don't. Like Andrea said, I don't know what to do with the results sometimes. And she even said from the stage, like, oh, I get this test and it creates all this anxiety and I don't know what to do. That's not a good position to be in.
But that will be clarified with the randomized. So if we can do ctDNA analysis in the neoadjuvant trials, the perioperative studies, and we've got these two.
We just need more data.
More data, great.